You're listening to The Dental Guys, episode 21, Cementing Zirconia Crowns. Do we have a problem? Are you having problems with your zirconia crowns debonding? We've heard reports saying everything from this being a huge problem to no problem at all. What is the reality? We discuss the research on zirconia bonding, and we'll go through our own protocols for cementing zirconia and all of the other types of crowns we use in our practices with products and protocols included. Plus, Brad, the lab guy, weighs in on his perspective of what might be causing the problem. Don't miss this episode of The Dental Guys. Welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And we're joined once again with Brad, the lab guy. Hey, Brad.
Hey, guys. Thanks for the invite. Appreciate it.
Yeah, man. We're glad to have you back. And it's a great time of year for vacation time's coming. I'm excited about that. Summer's almost here. I had a great end to my day today because I had a case that, man, both you guys know about this case. Very tough case. And I delivered 8 on an 8 implant lower, all screw retained, mostly individualized temporaries with basically no adjustments. And that was sweet. But every time I see this girl now after this bad thing happened, always makes me nervous.
What kind of bad thing are we talking about, John?
A few weeks
ago. That sound pretty bad. He stopped. That's a bad thing.
Yeah,
is it why I hate being a comprehensive dentist?
It goes back to that episode we had a few weeks ago about hating to be a comprehensive dentist because now you're actually expected. Now you're actually expected to deliver. So I was doing this immediate load conversion on this girl on 8 lower implants where I was picking up all of these individualized one piece temporaries, and it took me forever because of some issues we had with the specialist office. Unfortunately, I mean we pulled it off, but we had some issues, and we pulled it off, and it looked great. Everything was great. And of course, all you have to do is keep this one piece temporary from fracturing or anything like that until you're ready to load it for, with the next step. So everything's going great. I'm checking her out. She goes to the specialist for him to test the implants, do a torque test of the implants, takes off the temporary, does his torque test, puts it back in, and then I get a call. I get a call about 3 p.m.
No.
Hey.
Oh, no.
Sorry.
Oops.
I was putting your temp in and broke it, and it shattered not just a straight fracture, but all of the temporary PMMA fractured from the cylinders, which are non-indexed, all on the whole left side. So it's 3 o'clock.
Man.
He's like, man, I just don't know that if I can fix this. This is going to be on you. And of course it is on me. I mean, I got to fix it. So she's driving an hour and a half to come to me for me to fix it, and that was a long night. So when this went today, I cried one tear of joy. It was
just one.
I mean, I was really because
John doesn't cry, so if you
that's good. That's a lot. And
one tear is serious.
I mean, that's worth probably 10 of mine.
Yeah, that's true. I am a man, and I don't cry. Real men don't cry, or I don't know. It was one of those cases where you want it. It's a great case. It's fun. It's exciting. But when something like that goes wrong and the specialist gives you that call, hey, I'm sending the patient over for you to repair an 8 implant, 1 piece temporary and you don't have any other backup plan. You're like, well, I guess here we go. Man. So anyway, but one of the things that we have brought up on this show repeatedly about being comprehensive dentist is knowing about how to understand repairs and problems, and it all comes back to what are we actually learning? How do we learn these things? It's through research, it's through reading. And our episode today, we're going to be talking a lot about that, Wes, about some things that are new, some questions that are brought up, and we're going to try to address them. Tell us about the main topic today, Wes.
Well, you talk about reading, and people say, well, how do you all know these things? Well, we don't just come up with things, we have to read them, we have to understand why we're doing what we're doing, because I think that's what makes a really good dentist, period, is journal reading. And if you don't read journals, then you have to wade through, CE. And if you don't go to CE, which a lot of people don't, then you rely on other people. Mm-hmm. And so the other people that you're relying on are either dentists or laboratory technicians, people that have had experience with whatever it might be. So what are we reading? Well, one of the things that we've always said is a good resource for just good nuts and bolts dentistry, and I know Brad has a lot of respect for the people, Gordon Christensen, and especially Rella Christensen, who has done some amazing research over the years. One of the things that we've recommended in the podcast before, John, is that if you're a new dentist, and even if you haven't heard Gordon in a long time, I think it would be good for you to go and hear him talk about some of the top things in dentistry that is going on, maybe things that you might want to purchase for your practice. And something as simple as subscribing to their journal, which is not really a journal. It's more or less like a newsletter, I would say. Yeah. It does cost a little bit of money, but I want to give a shout out to Gordon Christensen and the Clinician's Report. It's been around for a long time. I remember when I was exposed to it as a senior in dental school and then followed up with in residency. And so they just do really good quality reviews on products. And
Brad, it's a good overview. It's a good overview.
Right. Before we go actually into what we're going to talk about today, Brad, what's been your opinion of Gordon Christensen, Rella Christensen over the years? I know you've had some experience with these two individuals. And what kind of thoughts do you have on those people?
First-class people. I've had a lot of dealings with Rella over the years. We did some early on in the Zirconia days with bonding porcelain to Zirconia. Rella and I did some studies and supplied them with some crowns that they did their studies with. But they do their research. They do it well. When they publish, it's it's really good nuts and bolts take-home stuff. So 100% shout out to them. It has been good stuff over the years. We as a laboratory subscribe to it.
So the thing that I like about this particular topic today is it's nuts and bolts dentistry. How many of you right now have had problems with crowns coming off, specifically zirconium crowns? Right now, Brad, you've mentioned in your lab, what percentage of crowns are zirconium that are coming out of your dental lab?
76, 75, 80%.
So the majority of crowns are not porcelain fused to metal. We've moved to something that's more aesthetic. We've proven that zirconium as single units and even 3 and 4 unit bridges is really at that or better than porcelain fused to metal. Now, there is some arguments there, but the research is to back that, and John will agree that we just don't do very many PFMs anymore unless it's something underneath a partial denture for that we're doing precision attachments, and even some of that can be eliminated. But the thing that kind of caught John and I's eye was recently in the May 2016 issue, Volume 9, Issue 5, the very front page, second paragraph, overcoming problems with cementing zirconium. Now, one thing that I like about Gordon is he gets right to the point. Mm-hmm. And the interesting thing here is that he begins to quote some good research. Just like good dentists should do, we should go to the books and say what has been shown to work. And am I doing something wrong? Because are there other studies out there that show that, are they having problems? Because zirconium oxide ceramic has been it's just been incorporated into dentistry like no other material that I've ever known. Brad, have you ever seen a material that's been incorporated in dentistry from as far as a standpoint? There's
nothing. It swept the market in record time.
Right. 95% of clinicians that are surveyed in this article actually currently use zirconium. Yeah. So like other materials, zirconium does suffer from bond failures or adhesion failures. And so 31% of the people indicated that they've experienced debond, but usually in less than 5% of restorations. So there was 2 research trials that showed positive results. At 6 years, full zirconium single-unit crowns cemented with resin-modified glass ionomer, something like Fuji-Sim is one of those, Reliax, Luting cement. That's a resin-reinforced glass ionomer. Those are 2 brand names right there. at 6 years showed 0% debonds. At 11 years, 3-unit zirconium framework bridges cemented with resin-modified glass ionomer show only 4% debonds, similar to metal control bridges. Despite this success, there seems to be a continued problem, John, with cementing zirconium. So did we have this problem with PFM? Was there an issue here? So what the article goes on is actually how to cement zirconium. Now this is where and what are some issues to bring up when you're having problems. So how many of you out there right now are listening to this podcast and you have crowns that are coming off? Okay, now we're going to tackle in this episode, not only are we going to tackle zirconium issues, but we're going to talk about E.max issues. We're going to talk about how to cement E.max to zirconium, how to cement zirconium to zirconium, how to cement zirconium to the tooth, and how to bond E.max, notice how I said cement, and how to bond E.max to a tooth. And should we be bonding, and when should we be bonding? John, I want you to take this article and kind of break it down for us. And what did he find?
Well, I think that he was pretty diplomatic in the way that he presented this, and the fact that he said, right off the bat, essentially what he said is, we're not having this problem. He basically said, hey, there's people reporting this, and there's 31% of people that have had a debond, but that's usually in less than 5% of restoration. So, and then you look at that compared to PFM. The question is, is it more frequent than PFM? And then he goes right ahead and shows us his cards and says, well, look, so we got 6 years, and this is just Gordon, but he's got 6 years on single units with 0% debonds using our MGI, which in theory should be the worst, in theory. And then 3-unit.
If you're new to dentistry, and some of you guys are, hey, listen, new dentist. What's RMGI? It's resin modified glass ionomer. It is a conventional cement. It's a little bit, it's better than the traditional zinc phosphate.
Right.
Okay?
It's a fluoride releasing cement. It doesn't have expansion like the old glass ionomers, so it's
that's bad.
It's a safe cement to use, but it really has very low bond strength. It's not designed to bond. It's a luting cement. No. It's designed to lute the restoration in place, to keep it from moving, to keep it from dislodging. It's relying on the resistance and retention form that you create by your preparation, just like zinc phosphate, with maybe a little slight added bump in bond strength. But then he shows it 11 years, 3-unit Zirconia framework bridges with 4% debonds, which again, he makes sure to say it's equivalent to metal control bridges. So right from the beginning, he kind of says where they stand, that they're not having this problem. But then he goes in and says, hey, okay, if you guys are having this problem, then let's talk through some potential things that you can do. And he goes...
And Brad,
go ahead.
Before you go on here, I'll interrupt. Brad, do you have doctors calling your office that have problems?
Every day.
Every day.
Significantly more on zirconia?
And significantly more on zirconia, definitely. Okay. There's definitely something that's going on out there. And maybe in clinical research they didn't show it because they're doing everything by the book, starting from the baseline, starting from the preparation.
So you're saying that with 81 or 80% of your crowns coming out of the lab, I don't know if you have data on that particularly, but can you give me a feeling for a percentage of, like, are you having this happen to 5% of all your crowns, 10%? Is it tough to say?
I have absolutely no data on it. It's based off just telephone calls that I've had, over time. And especially in Zirconia kind of swept the market. It was much worse. It seems like it's gotten a little bit better. I think people have read these articles. They're adapting and changing.
Yeah.
I think some of these cements have changed a little bit to the marketplace also.
Yeah.
So it's gotten better, but I still have a periodic
these calls.
Absolutely.
Well, Gordon, I think in this article says he kind of attacks it from two different directions as far as ways to potentially help this problem. He goes into just mechanical retention in the crown, and then he talks about what you can do to the tooth or with bonding. And, you can read the article for yourself. We're not just going to, read it to you, but we'll just say there's several ways that he goes into, including, air abrasion, roughening crown walls, things like that, adding retentive features to your crown. And then he goes into things you can do to bond, and then ways you can maybe create a less contamination on the surface. And he goes into what you can do and how to actually select a cement. And, I think that his essentially what it sounds like he's doing here is saying, kind of let's review all the things that are potential reasons why you could have a problem with cement failure. And I think that maybe the question that this brought up when Wes and I were talking about this and talking with Brad about it was, is this a problem with zirconia? Or is there something else to this? Because we did not seem to have this problem with PFM. Is that right, Brad?
Well, first of all, John, are you having a problem?
I'm not.
I mean, I've been practicing since 2003. I started doing zirconium in 2003 with a dental lab in the Northeast. And I haven't looked back since. And I eliminated PFM from my practice, not completely. I mean, I still use it to some extent. But not, I would say, less than 5% of the time my restorations are PFM.
Yeah.
The only time I have crowns come off, and you can ask my assistant. I mean, I'm not too proud. I mean, I'm just saying, like, the only time I have crowns come off is when I violated certain principles.
Yeah. The same things you would say with PFM.
The exact same thing. There's no difference between what comes off and what doesn't,
I'm with you.
If I violated principles of basic design, then I have violated, then I will, you'd have to tell the patient that this is questionable.
Yeah, you pay the price when something's not ideal,
right? And
you try to make it work, and sometimes we do this.
My question if Brad, you're seeing more come off, and we've talked about this, on the show before, then why are we seeing so many? Are we seeing this even an issue? Why is it even being talked about?
So I got a theory here, and you're not going to like it. And the reason I say you're not going to like it is because it sounds harsh, and I'm not just trying to be harsh, but I just think people are not doing a good job prepping crowns. I mean, they know what they're supposed to be doing, but they're just not doing it.
Do you think it's just pure speed that they're just prepping too fast, or?
Yeah,
let me throw something at you guys here. I got a thought for you.
Yeah.
What do you think if, years ago, and you're right, John, I know where you're going here. And my dad did this for 42 years. And in one of the universities, Marquette University in Wisconsin, always, and I'm sure a lot of universities, and you guys might have been trained with, is to do a very parallel prep. So you'd really hardly even need cement because it really is audacious and it holds on well. Well, now all of a sudden CAD-CAM came out and everybody's driving CAD-CAM, and initially everybody says, well, you got to do a taper on your prep. Mm-hmm. Do you think that maybe we took that too far?
That's what I'm.
You think maybe we're over tapering those preps a little too much?
What do you think, Brad? You see the preps every day. What do you think?
I think definitely because we started preaching it because a CAD-CAM you can't scan parallel preps, or at least anything with an undercut it won't scan around the corner. Well, then everybody's teaching a parallel prep. What's parallel?
Crowns cement the fastest, John, to TP style prep.
Absolutely.
Yeah.
I mean, if it's
they cement the fastest.
They cement the fastest, and they temporize the fastest.
Fit checker. Remember, when's the last time? Let me just ask you this: when's the last time you had to pull out fit checker for the inside of your crown?
It's like once a year.
Yeah, seriously, I had to pull it out the other day, and Megan's like, "Man,
when it comes out, it's a bad day."
Yeah, it's like the spray can and all that. And remember that Fuji actually had a product, Brad, if you remember this, you mix it up, it was like a little thin, really, a little pasty. It was like a PVS.
That's what GC Fit Checkers, that's what I use.
That's GC Fit Checker. Yeah. That's it. I have that too.
Yep.
But man, like when's the last time you had to do that?
Yeah.
And so, I mean, our burrs already have built-in taper, but I mean, goodness sakes, like should you be leaning that thing over at all?
Right.
So, Brad, what you're saying is that you're blaming it on the lab telling the dentist to give him more draw?
I'm not saying the lab. I'm saying the industry. I'm just, you got CAD-CAM that kind of came out before you used to wax everything and hand wax it. It kind of didn't matter. We could make anything work.
I think it's a reasonable theory. I mean, it makes sense because I didn't think about it from that perspective. I just thought about it from the fact that I've seen preps, and I don't have nearly, Brad is the man as far as knowing this, but the preps that I see oftentimes when I see people scanning, because this is where I really see like a lot of preps like CEREC doctors kind of guys where they show their preps, because there's a lot of guys, you go to CE and somebody's talking about how they scan something, you get to see their prep, and I'm like, oh my gosh. It's very short because, it's super gingival, so we don't have to worry about even creating prep length. And then it's super tapered and it's very reduced. And it's LVI on steroids. And, in terms of the reduction and over tapering, because those things tend to go together. Reduction because of need for material bulk, because of strength issues that we used to have with like Empress. That is, I think, maybe started the issue. And then you get in, like you say, CAD-CAM. Maybe that was the other nail in the coffin. I don't know. But I look at Gordon here, and I see him spend a great deal of time in this article talking about retentive preparations. And
because
what's a questionable preparations?
Exactly. Highly angled walls, imperfect margins, loose-fitting crowns, cement expansion joints. Brad, you've talked about this, is that how many labs actually go as far as you go to make sure that their cement expansion joints are calibrated and done and chosen properly? Because before, it was basically say, hey, use this die spacer right here because it has the cement expansion joint built in for resin modified glass imonomers or zinc phosphate. It's perfectly, you just dip your die in this and you're golden. Now, paint on this and you're done.
Now, Brad, let me ask you this though, Brad. Is there kind of like and just piggybacking this right off of your thought, Wes, what about from the lab side of things, when you're milling zirconia, okay, did you have, because you've been doing zirconia, I know, a long time, did you have problems initially with having to actually set your milling strategy to become essentially with more die spacer over time because you were having problems initially with too tight of a fit? Or could there be a trend toward labs making crowns looser fitting so that they don't run into problems? I mean, is that a possibility?
Absolutely. It's just a cement gap. It's a programmable cement gap, and there's several different features. It's not just one setting. So there's several settings that you can do to loosen a crown up. And the one that scares me is you can actually tell the computer to make it nice and a tight fit around the margin line. And 1 millimeter or half millimeter up, you can open it up and loosen it up.
Okay.
So it could have more of
where's the pressure at?
Where's the pressure at? Down towards the margins. But yet for the doctor, it feels like it's got a seat at the margins, but you could have really quite a substantial cement gap up high. Definitely
so John,
could be.
Case in point is I had a problem one time with a lab that Brad knows, a very good lab, before they had some problems. And they changed their cement expansion joints to do just what you said, to seal the margins up, but then they came up midways in the prep, and then they made their die spacer. And what was going on is I had a few crowns that I put in, and immediately the patient's coming back, and they're like busting margins off. What was going on was that all the pressure was at the margin.
Yep. There was no adaptation.
So this to make crowns seat, because you don't want that doctor to call back.
Yep.
Okay. Brad, what you're saying is that, well, we might fudge a little bit more than what's required.
You could, most definitely.
And that's where I go. So, I guess I'm saying there's a possibility that's maybe a trend that you couldn't get away with that so much.
More than I even thought could be a problem.
You couldn't get away with that on PFM because, like you say, you had to pull the pattern off. You had to, it had to be, so pretty much unless you like slathered on the die spacer, which you could do that.
You could do that.
But and it was hard, maybe sometimes hard to tell, but you could kind of get a feeling for that looking at when the model comes back, a lot of times if you got, a ton of die spacer on there. But, I guess I think about this as getting back to the article. I mean, is this really a problem? If we didn't see it with PFM, is this a milling problem or is this a prepping problem? And I don't think this is a milling problem. I know Brad is not doing this.
I don't think it's milling. I think it's prep design.
Yeah, I think it's prep design too. In the past, you could cheat the computer and anybody could do it. It could be a definite issue, but honestly, I come back to prep design. I had one of our accounts. He kind of had a hereditary problem of zirconia crowns coming off. And I know how you guys feel, and we all feel about Spears and the quality of education that they have out there. Well, recently, and Wes, you know this guy. You helped educate this guy. He went down and he took Spears' course. And guess what he came back to? His comment to me is, what I learned down there is I depend too much on my lab guy, Brad. Thank you, but I depend too much on you. I got to be the doctor. And I want you to evaluate.
Awesome.
I want you to evaluate my prep designs because I totally changed it based off of what Spears has taught me. So really, I'd be willing to bet you he went down there, was talking about debonds. They took him under their wing and said, "Look, here's what you need to do to change that," and they changed his prep design.
That's awesome.
So I think
stories like that, man.
Takes home just what we're talking about here. Why is Spears talking about it?
Yeah, because they're not talking about materials. Now let's go into the materials though, because it does bear discussion to say, okay, maybe it doesn't make, maybe it's the prep design. However, how should we be cementing zirconia if to get the very best?
Is all this stuff that we have out here to cement crowns, is it really necessary? You know?
Right, right. Because that's the next thing is, you just because the prep design is the most important doesn't mean
just knock
that
out one by one. Let's just say, what would you do if you were cementing a zirconium crown to a tooth? John, let's run through our recommended protocol.
Yeah.
And even based on research, based on this article, based on JPD, based on our evidence too. I mean, you have to use our bias because what we've done over the years as dentists and Brad's advice over the years. What do we recommend for cementing zirconium to tooth?
Yeah. And I think that, Wes and I are slightly different on this, not because we believe things differently, but just because we have slightly different protocols in our offices. But, for me, I have 2 cements in my office for delivering full coverage crowns. I have a dual cure resin with a separate self-etching primer, and I have a resin modified glass ionomer. And so for zirconia, I use resin modified glass ionomer for every zirconia crown, unless it falls into kind of, as Gordon says, the questionable preparation, where I'm worried about retention, which usually is something I'm aware of, the patient's aware of. But anyhow, what I do for my, typical zirconia crown, I do no priming, I do no preparation, I do nothing like that. I try the crown in, I do everything I would do for a PFM, I check contacts, blah, 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 and then we just cement it. I clean the crown with air abrasion, with aluminum oxide for 5 seconds, and then it's ready, and then steam clean it, and then it's back and ready for cement. I don't use resin. I don't use primers. I just use, just like Gordon says, he does the same thing I do for his recommendations. Not again that resin's bad.
John, is that 50 micron sand, 50 micron aluminous oxide, 2 bars roughly?
I use 30. It's a 30 micron, and it's set at, oh man, I got to check the pressure. I've got the little Danville micro etcher. I think it's set around 2 bars.
2 bars.
I think something like that, 1.5 to 2, somewhere in there. And so I give it one quick blast with that to make sure that I've got any contamination out of there, and then I'm back into to cement. And again, nothing wrong with resin, because I know, Wes, you do it a little differently.
Yeah, I take the crown off, I clean the preparation. I think Gordon brings up a good point, and a lot of us do this, is to pumice your...
Yeah, I always pumice too.
Your preps.
Yep.
I have to say that I haven't done that always, but most of the time you're gonna clean that preparation, remove the debris. The question is, where do you draw the line as far as cementing goes? Well, I do the exact same protocol as John. I'll take that zirconium crown to the lab. I blast it with an aluminum oxide, and then I'll bring it back, or steam clean it, bring it back, and then we're going to go ahead and cement it. I use a dual cure cement, bonded cement. I use Unicem. Not because,
because of course Wes knows I'm going to be like, why? Why,
right,
Wes?
Exactly.
Why do you do that if it doesn't matter? But there you have a good reason. You have a good reason.
It doesn't matter. But years ago, I read an article by Nash at the Nash Institute. He's a very good dentist, and if you've ever heard him speak, he speaks good practical, good Common Core dentistry. I like it. And so he had an article on how he eliminated resin and why he eliminated resin modified glass ionomer. And it's just basically because of protocols and systems in your office. Is that if you have multiple assistants, it's easier to teach one consistent thing and to do it the right way every single time. versus like, okay, we've got an E.max crown here. Yeah, we're going to use it something differently. Maybe we will. But for every lava or PFM crown, it gets Unisim. And so I just said, you know what, that makes sense to me. At the time, we had 3 assistants, and it was just easy just to eliminate, one more product from the thing, because products, man, they confuse everyone. And if you learn one way really, really good, you'll have good success. And I've had great success. Now, the question about that is if I was an over-prepper and I didn't use Conceptus or some type of HEMA on my preparations, okay, would I have sensitivity because of the moisture that Unisim pulls out of the dental tubules? That's the risk I'm running.
Yeah, you do have a slightly increased risk, especially from those that are the one component that don't have a separate primer and all that.
That's right. So I mean, you have to be careful about that. So the only reason that I'm bonding every single thing is not because I'm having debonds. It has nothing to do with that. It has everything to do with I'm eliminating one product from my office.
So let me tell you 2 other reasons why I like RMGI over that. Number 1.
Yeah, go ahead.
Resin's 3 times more expensive. 3 times.
Yes.
That's a lot. That's a lot of money. Number 2, because we cement a lot of Zirconia crowns. Number 2, how much do you love life when you have to prep off a resin bonded Zirconia crown? Because that's our future.
Case in point,
and
Brad's
years.
remaking a crown right now for me on number 15 is because I don't know, man. It happened.
I don't know, man.
And guess what's happening? It stayed on there. I adjusted the occlusion, and did I not? I set up the lady, and I said, "Guess what? You're coming back." And I'm having to mill you a new crown because the cement set up like a rock so fast. I didn't get it seated properly. How many times has that happened to me though? Maybe I could count on one hand.
Yeah, I'm just thinking about in 10 years if we have to start taking these things off because of recurrent decay.
It's a pain in the rear, dude.
Yeah,
it's
I'm
a pain
looking
in
at
the rear
that,
to cut off an old crown.
And I mean, it's gonna. I mean, I bond E.max most of the time, so I'm gonna have to do it too. It's just that with my Zirconia, I'm like, that's one less thing I guess I have to worry about.
So there's zirconium to tooth guys out there.
Yeah.
You need to clean your crown.
Mm-hmm.
After you try it in, don't just use water. Now, there's some other research we could go into. JPD talks about etching, hot etching techniques, and all this kind of stuff.
If you're using a primer, because this is what we're going to talk a little bit about. If you're using a primer on your Zirconia, because there's a whole other way.
Z Prime Plus,
right? Z Prime Plus, Monobond, those primers, and if you're using a primer. And it's the same with E.max. Once you apply a silane primer to your surface, it protects the surface from contamination really, really well. So you really don't have to go back and air abrade or anything like that if you are using a primer. But if you're not using a primer, like Wes and I on these, if you're just going to use either a Unisim or RMGI, then you really need to go back at the end and disinfect the surface of the Zirconia with something, whether it be air abrasion or Ivoclean.
Somebody out there I know right now is saying, I've been told to use primers.
Yeah.
And you're saying we don't need to, John?
Well, this is the article, and I know we can't dwell on it for very long, but there is a great article that is in, and we put it in the show notes. It's a Zirconia bonding review article in the Journal of Prosthetic Dentistry. Great article. Came out this last year. Talking about all the studies basically that from 98 to 2014, summarizing all the ways we've tried to bond to Zirconia and asking the question, how good is the bond and how long-term is the bond also? And this gets into some of our discussions too. We've had on other shows about hybrids and Zirconia and how good is that bond to the titanium cylinders, all these other things. But really the answer is there's not a great, totally predictable long-term bond. The bond strength can be pretty good initially if you do certain things, but long-term bond is not good. Why? Because it's hard to infiltrate into this material because it's so darn hard. Now, Brad, to get him in on this discussion, Brad over the years has developed a protocol in his lab, though, to try, probably using what the best technology is. Brad, tell us what you do to your Zirconia crowns when you send them out to your clients. How do you guys handle them to get the best bond strength?
So the best bond strength, there's a couple ways that we've analyzed. One, we sandblast 50 micron sand, 2 bars, clean it. Another way we've experimented with is using Rockatech. and we sandblast with Rockatech, leave silica behind. Now you can silinate or use a self-releasing silination, which you guys hate that. But you can silinate that crown and supposedly give you a little bit better bond. 2 ways that we've been working with it.
Gotcha. I was pretty impressed. I got a letter from Brad. This has been a couple of years ago when you guys really got into Rockatech and tribal chemical silica, and saying, hey, this is what we're doing. It's pretty cool. And the lab says to you, hey, we figured this out. We're going to be doing this whether you even know this matters or not. We think it might matter. That's pretty cool.
And really what that matters is when you're doing chemical bonding,
right?
Not conventional bonding.
Right.
Correct.
Right.
Or conventional adhesion.
Right.
So it would matter for me, it matters. Like adhesion,
Yep.
If I'm using Unisim, that matters to me.
Yep.
But it matters not for what you're doing, John,
No,
does it?
It doesn't. And again, there's a question of whether it matters even long-term anyway. Even if you do bond it, the long-term bond strength
probably doesn't matter.
Not great.
It probably doesn't.
No,
Probably
and that's why
doesn't matter.
and that's why even
It's
in 10 years
insurance,
when you're
so-
cutting these
Correct.
things off, it probably won't be a big deal, Wes. I mean, probably the truth is in 10 years, if you're taking off a zirconia crown that you put on
It'll
with
pop
Unisem,
off.
it's probably going to be the same as mine at that point, because the bond is not, we shouldn't be relying on the bond, is the bottom line from all this.
And how often has Gordon said that in his lectures?
Oh,
He
man.
says, I believe that eventually that everything becomes fluid and
yeah.
it's all flowing. Everything is
Right.
contaminated.
So it's all retention and resistance form.
That's exactly right. Retention and resistance form, learn how to prep, and you're going to solve a lot of your problems. So cementing zirconium to the teeth, I think, really just follow the simple protocols that a good person like a prosthodontist like Gordon has laid out for you in a journal. And we'll leave the link for this in the show notes as well, cementing zirconium. What about cementation of E.max? We've covered that in another episode, and I want to just rehash one more thing about this, is that right now current research states that we should be silinating our E.max crowns. Correct, John?
Well, research says that you do have an increased strength of the material if you silinate and bond E.max. It's not a tremendous difference. I think Brad backed me up on this thing. It's about 50 or 60 megapascals.
That's correct. Yep.
Yeah. So
That's what I've read.
it's 10% roughly, maybe less of a change. So it is an increase in strength. Is it night and day difference? No.
No.
But that's, now we're assuming though that we're ideal thickness, right? So if we're dealing with 1.5 millimeters plus of thickness of E.max, that's what those studies are based on from Ivoclar. They're not based on 0.8 or 1 millimeter. So it may become more important. I don't know. I don't think anyone's done that study to show at 0.8 or 1 millimeter, which a lot of times is what Brad's probably dealing with, is more like a millimeter or 0.8 with some of these, how much bonding matters. But there is some increased strength advantage to bonding E.max, I think.
So if you bond E.max, you should not, rely on a universal adhesive.
Yep.
For your silination.
As we talked about several episodes ago. Yep.
Several episodes ago.
Are you a silinator?
Are you a silinator? And you should be a silinator if you are using universal adhesives. Don't follow the manufacturer's instructions.
Don't listen to 3M or Kerr on that.
Well, actually, and some manufacturers have changed their protocols on this.
They're changing.
Yes, because you need to silinate.
Yep.
Okay, it's been proven if you use universal adhesives. I use universal adhesive, and I silinate after trying in. Okay, so go ahead, John. Go ahead, Brad. You got something to say there?
When you talk about silination, I can't remember if you guys covered this in the past, but it always used to be a fact that silination was only active basically for roughly no more than 12 hours. And I get a lot of questions all the time. And I was on site today when we bonded an E.max, and he asked, "Well, is this etched? Do I need to etch it with hydrofluoric?" And at least from our lab, we send it etched to the doctor.
Right.
Yep.
And it doesn't need to be re-etched.
It doesn't need to be re-etched. But when you try that in, it does contaminate that etch. So you do have to clean that back out. Just make sure you have no contaminants. But then his question is, well, do you silinate also? Well, we can't, because number one, you would contaminate it. And number two, silination never used to be active for more than 12 hours. And I don't know if that's changed or not. Do you guys know that?
I think that there's, it's the energy in that silane it dissipates quickly. And so
it has to be done at the doctor's office just prior to.
Yeah.
That's the way that we've always followed, and it advised the doctors too. So
yeah, I think that's the right call.
So, check out the episode "Are You a Silanator?" It'll go over that specifically on how to cement or bond E.max crowns or lithium disilicate. The second thing I want to talk about is, or third type of crown cementation is cementation of E.max to zirconium. Cementation of E.max to zirconium. Where does this come into play? Well, what if you had to do a cement retain restoration on an implant abutment that is zirconium? Brad, tell us a little bit about that, because we know this is kind of a hot topic as well.
Absolutely. Now you got a product that you can etch and silanate, and then you got a product underneath of it that you can't do either. So you kind of got a classic, make sure you're treating it correctly. And
most of the time, these are anterior restorations, so you have to look at stability of the resin color over time.
Color stability is so important.
You can't use an opaquer. You can't use a resin modified glass ionomer. It's basically opaque. You don't want that. So now you have to choose bonding. Okay, so how would you do this?
First of all, if you're doing over top of zirconia, we follow the same principles you guys do. I don't want to create a zirconia abutment, if you would, that's under contoured and doesn't have good parallel walls, because we can make the same mistake you guys make if we
resistance form, retention form.
It's the same thing. It's like prepping a tooth. We don't want to over prep or basically create an abutment that causes a debond either.
Yeah.
So that's where it starts. So it's same principles. Also, surface retention. We don't want to have a short abutment. We want to have as tall abutment as possible with as straight of walls as possible, just like you guys said earlier on the preparation. Starts there.
So the CAD-CAM technology allows us to do a full contour crown and then reverse engineer the abutment now to the exact specifications that you need. So
unfortunately, these are usually anteriors too. So you're not necessarily, although it's right, you want to over-engineer it. Usually the occlusal forces you're talking about are low. So you're not, even though you don't get a bond per se, the long term perhaps between E.max and zirconia, you don't have to necessarily have that strength. You just have to have something that doesn't get contaminated. I think you need to use a
color stable product.
Yeah,
that's the thing, is contamination, because how many of you guys out there have had the old black crown come back into your face? Brad, you were talking about this just before the show.
Absolutely.
Is that a patient shows back up and my crown is black.
Yep.
So what happened there is that, one, they probably used some type of viscostap to stop the bleeding.
Or just blood got in there.
Or just blood got in there.
Didn't pack cord or whatever when you're cementing, or do some 1-50, lidocaine, whatever it was, to stop the bleeding, and you just let it go.
1-50 lidocaine, guys. That's the thing, is like, these are little tools and pearls. Did you hear what he just said? 1-50 lidocaine. You say, I'll never use that. Let me just tell you, you put a quarter corporal of 1-50 lidocaine above number 7, 8, 9, and 10, and let me just tell you, you'll stop every bit of blood flow right there for just a split minute while you're cementing to really get that.
I did it today on a 4 veneer case.
It really does work.
Yeah,
it really does work.
Yeah, it works
Don't
great.
use it for like surgery or anything, unless what you're doing.
Yeah, don't be shooting people up with that stuff. But on the other hand, you put it in like an interpapillary injection, man, it's awesome.
Oh man, it's amazing.
Yeah.
Amazing. Just a little pearl right there. I think you don't want to brush over that. Packing cord with a little viscostat on there, and you contaminate the prep.
Yep.
You better be careful.
Right.
You got to almost pull that abutment out, re-etch it, then retorque it in place, all that kind of thing.
And one other thing I just want to mention before we go too far past it, just on RMGI, I do want to mention a product just real quick, because there is a product out there. One of the things I do hear sometimes from people that are big resin users, and again, resin's great, I use it all the time, is they'll say, well, with resin modified glass ionomer, you got to wait forever. Whereas with resin cement, I can light cure, tack cure, remove it immediately. And there's one product out there made by Kerr called Nexus RMGI, which is what I use. It's light cured resin modified glass ionomer. So you can tack cure it, immediately remove it, and then you can fully cure it just like you would with a resin cement. So I didn't want to gloss over that.
So it's dual cure resin glass ionomer.
Yeah, it's a great product. No one even knows it. I've never met anyone else that's ever used it.
That's interesting, because that is one of the main reasons that I left resin modified glass ionomer.
Takes forever.
I like to tack cure it. Takes forever.
Takes forever.
So this is new for me.
Yeah.
So how long has this product been out?
It's been out for 5 years. When I talked to the Kerr,
when did you start using this?
I started using it about 3 years ago. My Kerr rep, who's a great guy, he just brought some to my office. He said, we don't sell any of this stuff, but take a look at it. And I was like, this is amazing.
Really?
And he said that what happened is that during this time at Kerr, there was a changing of the guard and when this product was released in the marketing department, and they basically the marketing just completely fell apart. They didn't ever do it. I have never seen one marketing campaign, one ad for this material.
This is why I don't know about it.
Exactly. And of course, RMGI is not sexy. It's not like, it's not as sexy as resin cement, but it's a good material. And the only downside of it was always that waiting time, because it could take 3 minutes to sit there, and now you can tack cure and get in there right away. And so Kerr, and it's very inexpensive compared to like Nexus resin cement. So it's a cool product for what it's worth. If you're looking for an RMGI, Fujisim's great. All these others are great. Reliax Luting, but that one's got a little bit of an edge, and no one ever markets it. So for what it's worth.
Okay, John, go ahead and just tell us the 3 cements. I know you've got 3 cements in your office primarily for cementing, let's say, for long-term restorations.
Yeah.
Go ahead.
Yeah, so I use the Nexus RMGI that's my resin modified, so that's for all my Zirconia, PFM, E.max if I want to cement it, not bond it. And then I use also Kerr's Nexus resin cement. I've used Multilink, great cement too, but I like, kind of like you're talking about systems, I use Kerr's bonding material XTR. Yep. And so I like XTR. It works with my Nexus. It's my primer and everything for that too, so I don't have to have a separate primer. And then I've got, so that's my separate self-etching primer, dual cure. I don't use a one like Unisem. I don't have a product like that. I like the separate primer, not a primer in my cement. Not that it's bad. I just like that. But anyway, and then I use of course, a light cured cement as well. I use Variolink Aesthetic. I like it. It's a newer cement by Avoclar. I used to use Reliax Veneer, great cement, but I really like Variolink Aesthetic. It's a purely light cured cement that I use for veneers. Why did you switch? Well, what I like about it is it's simplified. Reliax Veneer, the problem that I have with it is it's got so many choices, and I never used 90% of them.
So you're saying it was kit selection. You could actually
So Variolink Aesthetic has three choices. It's neutral, warm, and light. And so
interesting. So they don't even do A1, A2.
No, it's neutral, warm, and light. Because what they're saying is, look, guys, if the veneer is so far off that you're having to use this crazy stuff, just send it back to the lab or do something. And don't try to do.
You can only minutely change shade anyways with that cement. I mean, it's so minute.
So if you want to go
you can't really rely on cement.
Yeah, you want to go a little 90%
warmer. 90% of the time you're using translucent anyway. Aren't you?
I've never even used the warm or the light, but I have them, and I don't have all this extra stuff that's just going to expire on me. So that's the only reason. They're great. That's a great product, but so is Reliax Veneer. Blah blah.
Brad, tell me the cements that you are recommending right now.
I want to touch right on what John was going off of with veneers, because I want to make sure maybe a new grad out there is kind of going, well, why do I need a special cement just for veneers? So let's touch on that real quick.
Not
John,
a dual cure cement.
Not a dual cure cement. So it's light cured, light activated. Say it again
really loud, because I had somebody cement veneers in the residency with a dual cure cement.
That's why I'm bringing it up.
They did it. Tell me why it's bad.
You don't want to do that. Dual Cure has 2 products in it to activate the setting of the resin. It's amine and peroxide, and when those get mixed together, it chemically activates. And the problem with that, when it chemically activates over time, now you're going to have traces of that amine that's unactivated, and it will discolor your veneer over time. Looks great today, but in 2 or 3 or 5 years, all of a sudden you get a dark veneer and you wonder why. It's the cement.
We've said you don't know if you're a good dentist until about 5 years.
Yeah.
So you figured it out by then.
And
we just hopefully saved it. They saved you. We just progressed you faster now.
I made that mistake when I got out of school. I didn't know, and I used Panavia on a case. I used Panavia, great cement, but I used it on a case, and here was the situation. I had 4 crowns, 7 to 10, and I had 2 veneers, 6 and 11. They were all Empress, okay, so very translucent. I cemented it all with Panavia. Man, it looked beautiful, and I think it was the yellow Panavia, which is like an A3-ish, and so it looked great for like a year. And then 6 and 11, man. 6 and 11, because they were the thinnest, started yellowing out on me. Oh, it looks so bad. And this came in with looked like two corn kernels, 6 and 11. And I learned that lesson very quickly because I think I forgot that day in dental school or something.
Oh, man.
Yeah, it was a bad day.
That's bad.
Redo.
Corn kernels.
Redo.
So, Brad,
It's
you're
the lab's
saying...
fault.
Brad, tell it.
It's always the lab's fault. I thought we made that status quo. We know that. It's always the lab's fault.
I don't even need to say it. Yeah, we know whose fault
the
that
lab
was.
sent me this cement in the mail, and I used it.
Yeah, it's their fault.
Yeah, exactly. They'll remake it. Don't worry. It'll be free.
So, Brad, your favorite cements?
I am a good 3M fan just because I know that they do a lot of good clinical research. So, I do like their cement for veneers. Their Relax Veneer Cement is a great cement. I do like Ivoclar's product also for cementing veneers. Great product line there. I do like the Ivoclar, 3M's Unisim has been a good product also for cementing, and kind of their new hybrid now that allows you to either etch or not etch is the 3M's. And I just drew a blank. Help me out, guys. Their dual cure resin. They have.
Yeah, it's the green. It's the Relax
Ultimate. Relax
Ultimate. Excuse me. Yeah, just totally drew a blank.
Don't confuse that with Relax Ultimate, the product they took off the market. The restoration.
This is so. Yep, this is it's a cement
it's a
dual
very
cure.
good dual cure cement.
Yeah.
So when you're cementing, I do a few inlays and onlays, and you've got deep walls down in there that you can't get your curing light to. You don't feel comfortable with curing that. The Relax Ultimate for that. So
on the glass ionomer side of things, Fuji got a lot of doctors use the Fuji cement, and they have for years. So
great product.
So my cements right now, Unisim, of course, I'm using that, and then Relax Ultimate for my inlays and onlays, Relax Veneer Cement for my E.max E.max veneers. Anything less than 1 millimeter to 1.5 millimeters, I'm going to use a Relax Veneer Cement. If I can get a light to it, I like that product mainly because I know it's very color stable, and I've used it for so long. That's the thing, is you get comfortable, but make sure what you're doing out there, cementing crowns, you're cementing with a proper protocol. Most of the time, I want to say this, most of the time, the instructions they give you in the box are the right way to do it.
Yeah.
Most of the time. Okay? I think that's one thing that the guy behind Danville Products, Bertolotti, made clear to me whenever I was a dental student, is he said, follow the manufacturer's instructions. Now, we know that there are a few things that came out. The dental guys brought up the fact that we need to be silinated and not relying on universal adhesives for silination. Those are little hiccups along the road with new products that you might have. But most of the time, follow those instructions. They're exactly to the T.
You don't have to reinvent the wheel.
You don't. And that's the thing. Gordon brings it up, is that first thing we need to go back to is we need to choose retentive preparations. 3 to 4 millimeters of vertical tooth tissue above, that you have good ferrule effect around cores, and don't end margins on cores, and don't create a bunch of products underneath the crown. That's another thing, a little pearl that I learned from a very good dentist. He said, Wes, minimize the amount of chemistry underneath the crown. So be careful, be wary of using lots of bases around and under crowns. Wouldn't you say it's a good tip there, Brad?
Oh, absolutely. Absolutely. Good core value. Good core value tips.
So the guys, this has been fantastic episode. There's a good meat here.
Yep.
And I want to first of all say that there's a great episode, and we've mentioned to it again, Are You a Silinator? You need to go back and check that episode out, because we bring up some good research of some things with these universal adhesives that you need to be silinating. Go back and watch that. We'll link to that right now in the video. If not, it's in the show description if you're on iTunes.
Yep.
And I want you to give us a review on iTunes. And I want us to, if you're on Android, you can do the same thing. Whatever podcast grabber you're using right now. I know that one of the things that we like to see is feedback on Facebook and Twitter, and we've got good responses on that. It seems like we get direct messages every week about something or some question that you guys might have. If you have questions regarding cement, Brad, the dental lab guy, can help you out with that, because he's been around for a while now and knows how to cement things properly.
27 years. I got age on you guys. That's scary.
Yeah. And that's why you're on here, because, man, the knowledge you have, especially when it comes to milling and zirconium. I mean, one of the pioneers right here in the industry. We have him on the podcast. I really appreciate it. Thank you so much, Brad, for coming on the show again tonight. And then John, I think one of the things that you brought up to me is there's always these products behind the scenes that we never really hear about because it's a smaller company and maybe they didn't invest in marketing. But this Nexus product, this new resin-modified glass ionomer that is dual cure.
Yeah, it's interesting.
And that's very interesting to me, and it's intriguing, and maybe I need to give it a shot. And so for Wes, the dental guy, and John, the dental guy, and always Brad, the dental guy, I'm glad to have you on the show.
Hey, thanks, guys.
Really appreciate you coming out. It's been a great show. So I'll say goodbye now. And this is Wes again, and we are the dental